Hello there, my name is Peter Reynolds. I'm a consultant neonatologist at St Peter's Hospital in the UK, and I'm talking to you today on the subject of caffeine in modern neonatal care. And this is an update talk, and I'm very grateful to Professor Ramanathan, the organising committee at the Neonatal Perinatal Medical Forum, for inviting me to do this talk. And I'd like to thank the coordinators and also Chiesi Pharmaceuticals for all the support that they've given to date. So in terms of updating about caffeine, I'm just going to cover a few areas that I think are interesting. The first is a little reminder about the pharmacology and the mechanisms of caffeine in the preterm newborn. Then I'm going to cover the use of caffeine in clinical care and cover some of the areas that are distinctly uncertain. Talk about how caffeine influences important clinical outcomes in babies, and then try and deal with some of the typical controversies that exist around caffeine, and finishing up with some advice for developing your own guidelines locally. So on to the pharmacology and mechanisms of caffeine, or to give it its chemical name, 1,3,7-trimethylxanthine. Caffeine is distributed very quickly in the human body. It's got a similar molecular structure to adenosine, and its pharmacokinetics are not affected by the route of administration. It's a hydrophobic molecule, so it passes through biological membranes easily, and it distributes rapidly in the body without tissue accumulation. After oral or intravenous administration, there is almost complete bioavailability, and it's rapidly absorbed from the GI tract with minimal first-pass metabolism. Caffeine normally achieves peak plasma concentrations within an hour of administration, and the CSF levels in preterms are the same as the plasma levels. Caffeine has a long half-life. It is mainly eliminated early on in the neonatal period by renal excretion, and then there is biotransformation in the liver through cytochrome P450, and partially by xanthine oxidase, and the metabolism is something that increases with maturity and is regardless of birth weight or gestational age of delivery. Females metabolize caffeine at a higher rate than males, but there is a long serum half-life quoted anywhere between 60 and 140 hours in the preterm infant. Caffeine is known as a competitive antagonist of adenosine receptors, particularly adenosine A1 and adenosine A2A receptors. And through this, it has a number of effects, including increasing respiratory drive and also some anti-inflammatory responses as well. And these are considered to be important when we think about the improved outcomes associated with caffeine. I'm sure you know this, but caffeine has multiple mechanisms of action. If we consider the brain, caffeine is associated with increased neural activity and responsiveness to carbon dioxide, with reductions in hypoxic breathing suppression and anti-inflammatory neuroprotection. Caffeine also has a positive impact on myelination and maturation of oligodendrocytes, and has anti-apoptotic effects. Within the respiratory systems, caffeine improves diaphragmatic contractility and reduces pulmonary inflammation. It also has a diuretic effect, which is mediated via the kidneys, but has a positive impact on breathing. And cardiovascularly, it increases the left ventricle stroke volume and has inotropic and pressor effects as well. It also has effects on other outcomes such as ROP, and this is some interesting work which was published in 2019 looking at neonatal rats and their proteomic profile specific for ROP, showing that in neonatal rats with retinopathy compared to controls, there were changes in the proteome associated with the caffeine-treated population. Caffeine does have anti-inflammatory effects, but there are some concerns that at high doses it may be pro-inflammatory, and this was some work published in 2011 in 26 babies less than 30 weeks, showing various changes in cytokines. Across the 4 panels, you can see that at higher levels of caffeine, there were increases in TNF-alpha, interleukin-1 beta, and IL-6, and a corresponding decrease in the anti-inflammatory interleukin-10. So these effects need to be considered, but equally at normal caffeine levels, there was suppression of these inflammatory cytokines. So moving on to the clinical use of caffeine, I think we would all agree that caffeine is the standard of care when we are aiming to treat apnea of prematurity. There has only really been one trial which has addressed both the short and the long-term outcomes, and that was the CAP trial, which was published in 2006. This had 2006 infants with a birth weight between 500 and 1250 grams who were less than 10 days old and were randomized to either receiving placebo or caffeine treatment. The outcomes showed that caffeine started within 10 days of birth reduced the need for subsequent respiratory support. And these effects, along with reductions in bronchopulmonary dysplasia and significant PDA, accounted for just over half of the primary neurological outcome improvements that were seen at 18 to 21 months, implying that there was a direct effect of caffeine on neurological improvement as well. You will be familiar with many of the CAP study outcomes, and this is a study that went on to follow babies not only at 18 to 21 months, but also through 5 years and to 11 years. And even at 11 years, there were statistically significant differences between the caffeine-treated group and the placebo group in terms of motor function. Again, implying that caffeine has long-lasting effects, either directly or indirectly, on the outcome of these premature babies. So when should we start caffeine? So in the CAP trial, the median age to start was 3 days. And in babies who started caffeine within 3 days, they showed shortened periods of requiring respiratory support than those who started treatment later. Another analysis done in 2014, published by Dobson, looked at a large population of babies retrospectively, showing that a smaller proportion of babies died or survived with BPD if caffeine had been started early compared to the population where it had been initiated later on. And these give some evidence to early treatment being beneficial. In fact, there's quite a lot of studies, and I'm not going to go through all of these, on early versus late caffeine. But rest assured, you can see that between 2010 and 2017, there were quite a lot of studies, some cohort analyses, and some randomized controlled trials, and some systematic reviews that have looked at these effects and generally showed reductions in death, reductions in BPD, PDA, and in some cases intraventricular hemorrhage in babies started on early caffeine. In terms of meta-analysis, there seems to be some evidence that early caffeine is associated with improved outcomes. This was some work published by Peter Davis that appears to show for some important outcomes, such as death or major disability, cerebral palsy, BPD, and treatment required for PDA, that the early use of caffeine was associated with improved outcomes. So bearing all that in mind, here's a clinical scenario. You are managing a 24-week infant with no antenatal steroids on board. The baby has been intubated in the delivery suite and a dose of surfactant has been given. The baby is brought round to the neonatal unit and umbilical lines are placed. It is now day 2 and the baby remains on mechanical ventilation. The FiO2 is still 45% and X-rays show evidence of severe RDS and further surfactant is given. The clinical decision is to maintain mechanical ventilation for the time being. One of the junior staff has read that caffeine reduces bronchopulmonary dysplasia and therefore asks, should we start caffeine even though this baby is going to stay on the ventilator? So the question is, do we have good evidence to support the use of, or in babies who are ventilated for starting caffeine? And the answer is not really. The CAP trial didn't control for the clinical indication nor the type of respiratory support in which babies received caffeine. Furthermore, infants may have met the eligibility criteria for CAP earlier because they were less sick. In other words, they weren't ventilated or they were about to be extubated. CAP is also now quite an old study. The babies were enrolled between 1999 and 2004, and our neonatal practices have changed substantially, and we are ventilating for shorter durations and ventilating less overall as well. There have been a couple of observational studies published from a couple of networks that showed lower rates of BPD in early caffeine groups, but again, the group who received caffeine later appeared to be sicker. This study was published in 2018 and is a study around the use of early caffeine and weaning from mechanical ventilation. Now, this study was stopped early due to an apparent excess of deaths, and I've just highlighted some of the results because they're quite interesting. There was no significant difference between the early caffeine group and the control group in terms of BPD. Both groups actually received caffeine after the first successful extubation, so the only differences were that the group of the early caffeine group in 41 babies received caffeine at an early point, but this did not reduce the age of that first successful extubation and did not speed up the weaning from mechanical ventilation. Nor were there any differences in secondary respiratory outcomes. If you look at the smaller table at the bottom, you can see that there were differences in necrotizing enterocolitis between the groups, but these were not significant. And there were differences in IVH, but again, they were not significant. But nevertheless, despite a non-significant difference between the groups, the trial was stopped early. Looking at the populations of these groups, they were also quite different as well. There was a statistically significantly higher male proportion in the early caffeine group, and the APGAR scores were different, although this was non-significant. Furthermore, the age of randomization was quite late and might not really meet the criteria of early, as some of us might understand it. All the babies in this study were intubated for surfactant administration and were routinely ventilated. And again, this may not be the sort of practice that many of us would now undertake. And the mean duration of mechanical ventilation in both of these groups was 30 days, which again, we would take to be quite a prolonged period of ventilation. So it's very difficult to draw too many conclusions from this paper, especially as the control group may have had a survival bias. A systematic review looking at early versus late caffeine again seemed to indicate that early caffeine favored outcomes, gave favorable outcomes to things like BPD, but was not statistically significant for mortality, for PDA, nor brain injury. But nevertheless, the duration of mechanical ventilation in retrospective cohort studies definitely is reduced and favors the use of early caffeine in terms of reducing ventilation days. So should we use caffeine routinely in ventilated babies? Based on the available evidence, I don't think that we can necessarily recommend this. There is contrasting data on the effect of early caffeine initiation. It's very hard to distinguish the outcomes of babies who were loaded with caffeine for a planned extubation versus routine initiation of caffeine regardless of the intention to extubate. And therefore, in terms of improving outcomes, the important thing appears to be making a decision to extubate as early as possible and then using caffeine to optimize the chances of success. Here's another clinical scenario. You're managing a 24 plus 5 week infant and antenatal steroids have been given. You're able to start non-invasive respiratory support in the delivery suite and the baby comes to the unit where lines are then placed. Surfactant is given by less invasive surfactant administration administered via a fine tube because an FiO2 reached 30% and it is now day 1. The baby is still being non-invasively respiratory supported and is in air. Should you routinely start caffeine in this case? So there's quite a lot of evidence that very early caffeine improves breathing efforts. And this is an interesting paper that you may have seen published in 2017 by Decker, where they randomized 30 babies between 24 and 30 weeks to receiving caffeine in the delivery room given within 7 minutes of birth, or to receive it later at 48 minutes in the NICU. Now, we would consider both of these to be quite early, but nevertheless, these showed significant differences between the minute ventilation with the blue bar shown for the delivery room and in the tidal volume of breathing as well. So there's evidence that caffeine can exert positive effects on breathing very early on if it is given in this way. This was another paper, another double-blind randomized controlled trial of babies under 1,200 grams who were spontaneously breathing at 24 hours of age with a primary outcome of incidence of apnea. This was a small study with only 26 in the caffeine group versus 26 in the placebo group, but nevertheless, for that primary outcome, showed a significant reduction in apnea, in bradycardia, and in cyanosis, and also a significant reduction in chronic lung disease as well. There was nearly a significant reduction in the need for CPAP as well. The most immature babies in this study showed the greatest effects on the incidence and severity of apnea, which doesn't really come out in these tables. So it's an interesting observation, but it is a small study. Back to the CAP trial. Nearly 2/3 of the babies in the CAP trial were recruited for prophylaxis or treatment of apnea. So this may help to answer our clinical scenario. We know from the CAP trial that treatment with caffeine reduced the need for respiratory support, and that's defined as intubation, positive pressure ventilation, or the use of supplemental oxygen. And this was statistically significant compared to placebo. So should we routinely use early routine caffeine in babies who are receiving non-invasive respiratory support? Yes, there appears to be evidence to support this practice, but it is low-grade evidence. It can, of course, be argued that waiting to treat apnea of prematurity with caffeine would be a more evidence-based approach than giving prophylaxis for apnea of prematurity. However, given the prevalence of apnea of prematurity in extremely preterm infants, this purist approach is often replaced by a pragmatic one. I'm not sure that we would want to wait for babies to suffer a hypoxic episode before starting caffeine. And if you go back to the slide looking at the various mechanical and other effects of caffeine, there are other potential advantages that aren't just centered around apnea of prematurity. The most recent European consensus guidelines, which I'm sure you're well familiar with, state that we should aim to minimize the time that babies spend on mechanical ventilation, and we can use caffeine to do this. So in addition to using volume-targeted ventilation and using non-invasive respiratory support techniques and a degree of permissive hypercarbia, caffeine is included in that approach to the overall strategy. Early caffeine should therefore be considered for babies at high risk of needing mechanical ventilation, such as those on non-invasive respiratory support. So if we're going to start caffeine, what dose should we start at? Well, again, there have been numerous studies, and I won't go through these, comparing loading doses and maintenance doses, both high and low. Some of the loading doses as high as 80 milligrams per kilogram, with maintenance doses as high as 20 milligrams per kilogram per day. And interestingly enough, many of the studies with the higher doses showed reductions in apnea of prematurity, and some showed improvements in other important outcome measures, such as general quotient, as well as reductions in BPD and other important outcomes, such as mechanical ventilation. What dose of caffeine should we use? Well, the CAP trial used a loading dose of 20 milligrams per kilo with maintenance of 5 to 10 milligrams per kilo, and a retrospective analysis of the CAP trial showed that lower doses, less than 7.9 milligrams per kilogram, seemed to be associated with more clinical interventions. There was a study published in 2011 looking at caffeine in terms of its effect on development, temperament, and behavior. And this looked at 287 babies less than 30 weeks who were either loaded with 80 milligrams per kilo of caffeine with a maintenance dose of 20 milligrams per kilogram, or a loading dose of 20 milligrams per kilogram and a maintenance dose of 5 milligrams per kilogram. The high dose group showed statistically significantly fewer apnea of prematurities episodes, and also a higher general quotient, and they showed no significant adverse effects on temperament, behavior, or other effects that were recorded. Another study of 218 babies looked at early high-dose caffeine, and again in the high caffeine group there were fewer apneas of prematurity episodes and a higher general quotient as well. And a pilot randomized study in 74 babies again showed in the high dose caffeine group that there were greater incidence of cerebellar hemorrhage. And this report caused great concern because it seemed to show a threefold significant increase in cerebellar hemorrhage in the high caffeine group. So what dose should we use? Well, there is evidence that higher doses of caffeine may be more effective in reducing apnea of prematurity and BPD, and there may be some evidence in improvement on general quotient. However, concerns about serious side effects such as cerebellar hemorrhage need to be considered. Furthermore, we only have the CAP study that has given us genuinely long-term outcome and safety data, and therefore at the moment, the recommended dose needs to be the same as that study, which is a loading dose of 20 milligrams per kilo and a maintenance dose of between 5 to 10 milligrams per kilogram. This maintenance dose should be started 24 hours or more later after the loading dose has been given. And because of the long half-life of caffeine, this allows us to standardize the timing with ward rounds or with other medications as well. It may be justifiable to use higher doses, such as a maintenance dose of 15 or even 20 milligrams per kilo in individual cases. We must be vigilant for the potential side effects of caffeine, which may indicate toxicity, such as tachycardia, agitation, excessive diuresis, or gastric effects, such as vomiting. Serious side effects appear to be very rare, but arrhythmias and seizures have been described. So we've decided to start our caffeine and we've chosen our dose, so how do we continue it? Well, when should we switch to oral caffeine? Should we increase the dose or decrease the dose as time goes on? Is it important to have stable levels as the baby matures and apnea of prematurity becomes less frequent? When should we stop caffeine? And how long should we monitor babies for apnea after caffeine is stopped? These are all important questions. In terms of switching to oral caffeine, well, many guidelines suggest that it is safe that when a baby is on approximately a half to 2/3 enteral feeds tolerating milk, then this would be a good time to switch to oral caffeine. That's what I do in my practice, and we know that the oral bioavailability of caffeine is excellent. This was a study that was published in 2017 looking at caffeine dosing. Panel A shows the fairly standard dosing regime with a loading dose of 20 milligrams per kilogram and a maintenance dose of 5 milligrams per kilo per day. And you can see that the target level of caffeine of 15 milligrams per liter was reached after about a week and then slowly declined down towards about 12 milligrams per liter. Moving across to panel C, this is a higher dose regime with a loading dose of 20 milligrams per kilo and a maintenance dose of 10 milligrams per kilo per day, which achieves a higher steady state as well. And what Koch and fellow authors recommended was that using a adjusted dosing regime where you start with a 20 milligrams per kilo loading dose and 5 milligrams per kilo, but then to achieve stable concentrations, increasing the caffeine citrate dose by 1 milligram per kilogram every 2 weeks, achieved the levels seen in panel B. So this is if you want to achieve a stable concentration of caffeine, but of course some would argue that that might not be necessary. So when should we stop caffeine? Well, we need to avoid unnecessary delays in discharge. There is enormous variability between babies, as you know, that when apnea resolves. So using a fixed gestational age may mean that we're continuing caffeine unnecessarily. And one author, Eichenwald, recommended for, in terms of a guideline, that if a baby has been free of clinically significant apnea or bradycardia events and is off positive pressure respiratory support for 5 to 7 days or at 33 to 34 weeks, then this should be the time to come off caffeine. There is, however, some evidence that longer courses of caffeine continue to reduce the frequency of intermittent hypoxia. And I think that we all recognize that intermittent hypoxia is associated with poorer outcomes and is something that we should work hard to avoid. Babies should certainly be free of apneas for 5 to 7 days before they're discharged home, bearing in mind, in particular, the long half-life of caffeine as well. So this is an example guideline from one NHS group in the southwest of the UK, where if a baby meets the criteria for caffeine, then it will be started. This would be for all babies under 30 weeks or below 1,500 grams who are on non-invasive respiratory support or are about to be extubated. In addition, if babies are showing apnea of prematurity, or require early extubation or weaning off IPPV between 30 and 34 weeks, they would consider using caffeine as well. And then they refer to their caffeine monograph, which gives the standard doses. Babies should be monitored for oxygen saturations and heart rate. And then they stop caffeine when babies have not required positive airway support or shown episodes of apnea for 5 days and at least 5 days prior to discharge. Monitoring is then stopped 48 hours after the caffeine is discontinued. And this seems like a perfectly reasonable example of a guideline. Their stopping criteria are mainly symptom-based rather than gestation-based, and some people could argue that given the positive effects on neurodevelopment from the CAP trial, maybe babies should stay on caffeine until 34 weeks. I have to admit that I would prefer to use a symptom-based approach. We must avoid hypoxic episodes, but I think that we should be giving caffeine to babies who don't need it. A lot of people worry about the effects of caffeine on sleep. We all know that caffeine and sleep are important. Adenosine is an endogenous sleep factor, and in our brains, it inhibits the wake-promoting neurons, the A1 receptors in the basal forebrain, and it activates the sleep-active neurons at the A2A receptors in the rostral forebrain. And therefore, that cup of coffee provides some competitive antagonism by promoting wakefulness and causing fragmentation of sleep. And therefore, we know the effects of caffeine in us. Indeed, that's part of the reason we drink coffee. And therefore, there are understandable concerns that caffeine might disrupt sleep in preterm babies. So this was an interesting study that was published last year by Gilbert Koch and his group, which really gives quite a lot of reassurance to that. They did videographic recordings in preterm babies, looking to see whether they were wakeful and whether they were in active sleep or quiet sleep. So the largest proportion of sleep in preterm babies is active sleep, and this is a predecessor for rapid eye movement, REM sleep. And as babies become more mature, the proportion of active sleep goes down towards term. Quiet sleep, on the other hand, is non-REM sleep. It's slow wave on an EEG, and it's considered to be very important for physical regeneration, cerebral regeneration, and immune development. And quiet sleep remains stable regardless of gestation. So this study, they looked at babies below 28 weeks and above 28 weeks. Below 28 weeks, they saw no differences at all in wakefulness, active sleep, or quiet sleep. And above 28 weeks, you can see the graphs here, they showed a statistically significant increase in wakefulness and a commensurate decrease in active sleep. So the presence of caffeine, as the caffeine levels increased, seemed to increase wakefulness, but not at the cost of quiet sleep. Regardless of caffeine levels, the quiet sleep remained the same. And the authors concluded that caffeine does not affect the time for quiet sleep and therefore should not affect the time for physical and cerebral regeneration, which I think is very reassuring. There are even more questions that we can ask about caffeine. Does it aggravate gastroesophageal reflux? I get asked this frequently. Is it good for renal function? Should we use it for those babies who are on prostine for their duct-dependent cardiac problems to prevent apneas? And could it complement other treatments for apnea of prematurity? The answer about the reflux is probably it does. We know that caffeine causes gastric irritation. But in those babies around 32, 33 weeks who are having hypoxic episodes, it can be extremely difficult to know whether they're having severe reflux episodes, which are probably overdiagnosed, or whether they're simply having ongoing intermittent hypoxias from apneas of prematurity. And therefore, quite a careful diagnostic process is required. Is caffeine good for your kidneys? Well, the AWAKEN study, which was published in 2018, showed that there is a reduction in acute kidney injury of between 3- and 8-fold in babies who received caffeine. So it does appear to be good for your kidneys. Could it prevent apnea for babies on Prostin? The answer is probably yes, but the cardiologists don't like it. So that is usually a no-no. And could caffeine be used to complement other treatments for apnea of prematurity? This hasn't really been tested, but I think that watch this space is the answer. For those of you who want to read even more about caffeine, and particularly about the effects of caffeine in the developing parts of the world, there was an excellent Seminars in Fetal and Neonatal Medicine published in 2020, which was edited by Barbara Schmidt, the primary author of the CAP study, and I would direct you towards that particular publication, which is good further reading. So in summary, caffeine is the standard treatment for apnea of prematurity. It has an excellent safety profile, and we don't do caffeine levels because that's unnecessary. It reduces the need for mechanical ventilation. It facilitates extubation success. It reduces episodes of intermittent hypoxia. It reduces the risks of bronchopulmonary dysplasia, patent ductus arteriosus, and retinopathy of prematurity. It is associated with improved motor outcomes, and it forms a really important part of our non-invasive respiratory support ethos. It should certainly routinely be used in babies under 30 weeks and be considered in more mature infants. And dosing recommendations remain to load with 20 milligrams per kilo and maintain with 5 to 10 milligrams per kilogram per day, using more if necessary. Local protocols should define whether a gestation or a symptom-based approach is preferred for stopping, but regardless of that, babies should continue to be monitored for 48 hours after stopping, and the use of caffeine should not delay discharge from hospital. I hope that's been an interesting update for you on caffeine. Thank you.